Good afternoon, 1 p.m. Eastern Time, and other times for those of you who are there. My name is Bert Hoffman. I'm the chair of the Department of Epidemiology of the Harvard Chan School, and I am your host. And it's my great pleasure to introduce Dr. Joseph Koresh, who will speak in this series, in this seminar, in the series of the Department of Epidemiology. Dr. Koresh, welcome. Professor Koresh is the founding director of the Optimal Aging Institute of NYU, the Grossman School of Medicine. He is also the Terry and Mel Karmazin Professor of Population Health and Medicine, and previously he was at Johns Hopkins, as many of you know, highly cited and very much working in vascular disease and in relation to various forms of aging. Dr. Koresh, a great pleasure to have you. We are having it in a webinar form because of so many people following your seminar. So if there are questions of the audience, I will relay them to you. That you can put the Q&A in the chat. And I say this to the audience now in the webinar, and I will then bring that question during the Q&A. Dr. Koresh, please go ahead.
Thank you very much for the invitation, Bert, and it's a pleasure to join you. Let me know if people can see my slides.
I can, so I guess that's for others as well. Yeah.
That's good, and I'll get a laser pointer. So it's a pleasure to talk to you. I thought I would focus on dementia risk and prevention, lessons from the atherosclerosis risk and communities cohort study. So the literature is vast, and I'll sort of focus on one cohort because it can touch on some key points. So I thought I would give one slide on the Optimal Aging Institute perspective on aging. Then I would go into dementia and focus on lifetime risk, risk factors, and then some nuances that I think people may be familiar with but need to think more about because certainly I don't know all the answers. And then the last part of the talk is work that we're doing right now that has been presented and is in the process of being fully published on brain biomarker integration into prevention trials. And I welcome comments during the chat and by email because I think it's a major challenge. We've seen the Pointer study presented and lots of interesting work on biomarkers. So in terms of optimal aging, we think of function as well as joy and meaning being critical. And function often increases during development and then decreases. And if that's the average trajectory, we think of optimal as getting higher function. So in terms of education and cognitive function, you can start as early as birth or maybe even in utero, get a better education, and hopefully decline more slowly and not get to dementia if you're lucky. Then some high-risk individuals have lower function, bigger declines, and acute events like MI, stroke, or dementia. And I think it's important to realize that you can institute optimization at any stage. Midlife works very well. We'll talk about population attributable risk and risk factors. And you can also do it after events like an MI or stroke, and we're doing research on that. I think I chose to do this institute at NYU, Grossman School of Medicine, and Langone Health System in that integration of care with population prevention, with individualized work in collaboration with precision medicine and other groups is really quite an ideal strategy to look at this. To make it personal, this is my grandfather. At 57, he got a heart attack. And actually, they thought he was going to die. But this is him 30 years later with my grandmother. And I remember as a kid, she took away his cigarettes. She didn't let him do things. She got him going and she changed his diet. And he outlived all his brothers and sisters who hadn't had a heart attack at that point. She herself is an interesting example. This is her at her 90th birthday, really doing unbelievably well as a matriarch. On the other hand, we'll talk about disease at the oldest age. And by 100, this is her 100th birthday, she had already had several years of dementia. So we'll talk about late onset dementia and how we start dealing and thinking about that, which I think is a major challenge as I look at you, Bert. I think the aging of the world, we also realize, is happening for two reasons. One is birth rates are falling across the globe. So at this stage, I don't know if people realize, most countries, not just the US and Europe, but also China and now India, are below replacement levels, which means that the aging pyramid keeps getting older and older as we have fewer births and better survival. So we'll talk about some of those projections. The ERIC cohort that I'm going to focus on started with 15,792 men and women, middle age 45 to 65 in the late 80s. And a lot of the original investigators spent over 20 years, and now we just had a meeting yesterday of the current steering committee. 4 field centers, 25% African American, 1/2 in spouse pairs, so there's also a literature on that, many hospitalizations, many visits, and we just finished visit 12. So it's a lot like other landmark NHLBI cohorts, but it's getting quite mature and is in size able to contribute because of having both the standard visits, then imaging visits that I'll talk a little bit about, proteomics that I won't talk about in this talk, brain biomarkers, which I will talk about some, and then modifiable risk factors, outcomes in terms of cognitive function and impairment and dementia, which I'll focus on. So the first topic I wanted to talk about is lifetime risk of dementia. So what is the lifetime risk of dementia and why is it important? So our analysis starts at age 55, and we want to say if you follow people for the incidence of dementia before death, you need to consider death before dementia. It's a competing cause situation, competing risks, and we can get reliable estimates up to age 95, which is the majority of the people. So what percentage of the people will get to dementia before death or age 95? And we want to estimate that implication on future dementia trends if the population ages and if incidence doesn't change, which is a big question because there's been trends in incidence. So the previous estimate and the one that's most widely used is 20% lifetime risk based on really pioneering work from the Framingham Heart Study. But it's been a while since that analysis has been done, and Framingham, while pioneering, is older data. The cohort isn't that large, and a lot of these estimates are visit-based. And ascertainment of dementia is very tricky in that you need to chase cases because they do not come in our study to the visits. So we also contacted next of kin, did telephone calls, and did home visits. So Mike Fang led this paper working with Jiaxi Hu, who is a doctoral student who worked on the competing causes, risks, and a demographer in our group here at NYU, Jordan Weiss. I'll start with the bottom line. Our estimate in ERIC is 42%. You can tell that's higher, and it was published last year in Nature Medicine, so some of you have seen that result. I want to just talk about it in context before moving on to newer things as well. The methods were to look at the entire cohort over time. We looked at death and dementia through multiple methods, right? So we do cognitive testing at the study visit, and in some sense, that's the gold standard for knowing cognition. However, we find out that when people's cognition declines, they're less likely to come to visits. So we do semi-annual telephone calls, we invite them to visits, but if they don't come, we administer the 6-item screener, and then we look at their family members, we administer additional questionnaires, we look at their hospital discharge codes, which are available for both people who come and people who don't come, and we look at death certificate codes for those who, for everyone, and they can complete the data. So overall, we had 3,252 incident dementia cases, so the estimates become relatively stable, and we had even more deaths, 5,803, before dementia. So that's sort of the competing causes of death, and about 2,000 participants were lost to follow-up during this time. So the competing risks analysis looks at a cause-specific analysis where you look at the risk of death, the risk of dementia, and then you combine them into a combined curve. So that analysis resulted in this 42% lifetime risk. It's important to note that it's not all bad news. The risk by age 75 was only 4%, right? So a lot of these processes I'll show you start in midlife, as we know, but the risk by 75 is 4%, by 85 is 20%, and that means more than half of the experienced risk is in this decade from 85 to 95. So incredibly important, and important to have studies that have enough people at these very oldest ages to get stable estimates. And I should note that I focused on the Framingham US estimate. Rotterdam had an estimate of 33%, and then 16% in men, 33% in women, so higher than Framingham in between. And then recently there's been papers and preprints in the health retirement study that are closer to the 40% number. So this result is being replicated, and an important number to keep an eye on as we think about the future of dementia. We do see a higher risk in women than men. At least in ERIC, most of this is due to the higher survival in women, right? So it's going to be very important to think about whether women are at a higher hazard, and there's a whole biology in thinking about menopause, but there's also the fact that women just live longer. And if half the cases occur after age 85, then women are much more likely to make it to that time. A lot of the gap in our work is opening at that age. So now if we look at this by race, we see that African American individuals, now we should note that in ERIC, they are mostly from Jackson, Mississippi, so geography and place is confounded with race in ERIC. And so we see that the African Americans in ERIC developed dementia earlier and had a higher lifetime risk, despite having a somewhat higher mortality. And then by ApoE, again, we see the highest risk as expected by 2 ApoE alleles, intermediate risk with 1, and then lower risk with 0, but still substantial risk at the oldest ages with 0 ApoE alleles, right? And even with 2 ApoE4 alleles, in our hands, the competing risk of mortality means that you're not going to get to 100%. So when you look at papers, it's going to be important to think about whether you're looking at a Kaplan-Meier curve, where basically death is censored and risk can get very, very high. And some papers publish risk of 80% or more, but that's if you don't die ever before dementia. And people do die before dementia, even if the process is going on in their brain. So that's sort of the excess risk at different ages. To illustrate this in more detail, I'll talk about a paper that's ongoing by Jiaxi Hu about the number of midlife vascular risk factors. And it shows you that if you do a Kaplan-Meier analysis and you look at the incidence of dementia, censoring death, so assuming that if you die, you just look at the people and their risk of dementia, then you see that 0 risk factors versus 1, 2, and 3 risk factors, the risk is higher, and all the risks get very, very high if you don't take death into account or you censor it. If you look at death, you see that really by age 95, most people are dying, and the people with 3 risk factors don't even make it. We don't even have enough data all the way to age 95 because 90% or so are dead by the age of 90, as opposed to the people with 0 risk factors, where by the age of 85, 75% are still alive. So this is showing you that when you combine these two, what happens is if you have 0 risk factors here, you see a lower risk of dementia by age 75, by age 80. But by the time you get to age 85, the fact that 75% of the people are alive with 0 risk factor versus 20% with 3 risk factors means that if I have fewer risk factors, I am more likely to live past that age 85 and experience that second half of the dementia burden. So this is annoying. In some sense, we don't want to think that if I'm doing all the right things, I have a high risk of dementia, but it's not a higher hazard. I have a lower hazard. I just have more time to experience the very latest ages. So I think this is important, even though it's a nuanced message, and one can look at risk factors over time, and I'll show you a few more nuances. Right? This is the result for diabetes. If you have no diabetes, dementia versus death before dementia, trying to illustrate this complex concept. Whereas if you have early onset diabetes, in our data in ERIC, we have an increased risk of mortality and not that much, and an increased risk of dementia, but it takes time for it to express. And the increased risk of mortality reduces the experienced cases of dementia. If you have late onset diabetes, we see that you keep that increased risk of death, but the risk of dementia with late onset was not so much elevated. So overall, you're more likely to experience death, and you get this paradoxical effect, which Jiaxu, who published in Diabetes Care in 2024. So preventing and delaying the onset of dementia can reduce the risk of dementia, but it's a nuanced situation about dementia before age 80 and 85 and after. So if we have this high lifetime risk, and indeed we're seeing projections that the population is getting older and older, and the number of older adults over age 65 will outnumber the number of children under age 18, then we at least did the naive projection that says if dementia incidence persists, then our estimate is that the number of incident cases will double by 2060. And this is consistent with published estimates on the prevalence being 6 million people in 2020 and potentially more than doubling by 2060. Now, if we do the right things and can continue the decline in incidence of dementia, some of that is thought due to improved education. Some of that would be risk factor improvement, and maybe we can do more risk factor improvement. I think there's an interesting question of whether agents like GLP-1s, which are increasingly used, will improve dementia prevention. So there's lots at stake to try and prevent this doubling by 2060. And there's some controversy as to what would happen if we just kept doing exactly what we're doing now. And it's not clear to me how we do it and how it will be distributed across the population. I think that will be quite important in that we need to get to all parts of the population and not leave high-risk parts untreated. So that was lifetime risk. I wanted to go to sort of chapter 2 of this and talk about other risk factor nuances and prevention. So I wanted to start with the Lancet Commission report, which is really a landmark report, updated regularly, and does an amazing job of modifiable risk factors and estimating their population attributable risk overall, sending an important public health message about preventing and delaying dementia with a message that it's never too early or too late, but there are nuances. So what I wanted to do was talk about the nuances. So one of the nuances was pointed out by Rebecca Gottesman, which I think lots of literature, this is work from Eric, published in JAMA in 2017, lots of data supports this concept that midlife vascular risk factors are highly associated with late life amyloid deposition in the brain from 0 to 1 to 2 risk factors. In fact, it was dramatic to me that the midlife risk factors were actually more powerful risk factors than the concurrent Visit 5 risk factors in 2011, measured more than 2 decades later, right? It's also impressive that this happens in people with 0 ApoE4 alleles and 2 ApoE4 alleles, where the risk gradient was 1, 3, and 9 relative hazard for having amyloid in the brain. And it worked in conjunction with other risk factors. The amazing thing to me is that it suggests that the current thinking is that we have vascular risk factors being important for vascular dementia, but also for Alzheimer's dementia, which expands the scope for prevention by generalized strategies like the finger and pointer study and other strategies that I'll talk about as well, trying to address neurodegeneration and trying to address vascular disease. So then I wanted to go to the nuances. You know, if we try and look at the population attributable risk, Jason Smith, working here with Jennifer Deal and Richie Sherratt and a group of others of us in ERIC, trying to think carefully about what does ERIC say about population attributable risk, in particular by midlife and late life risk factors. I think this may be too nuanced to simplify in one diagram, but I think it's something that includes themes that people might have seen in many other studies. So first of all, in terms of the risk factors measured in midlife and then later in life, hypertension alone is very common, and then hypertension with diabetes, with smoking, and then diabetes doesn't occur as often alone, more often with hypertension or other risk factors. And then hypertension increases dramatically with age, which suggests that the population attributable fraction can increase dramatically as well. What happens to the relative risks by the number of risk factors or the risk factors themselves? The relative hazards we've seen in many studies are highest if you measure the risk factors earlier. And if in this case, it was high for risk factors later and earlier in life. So in ERIC, we get both early and late for dementia incidence before age 80. But what was really interesting in this paper is we followed up, and Jason did a very nice job of distinguishing dementia cases before age 80 and after age 80. And many groups have shown, including Claudia Kawas and others, that the risk factors after age 80 and 90 are much less predictive, and possibly we need to look for additional risk factors. So one risk factor had a relative risk of 1.2 for cases after age 80 versus closer to 2, 1.5 to 2.5 before age 80. Now that has dramatic implications for the population attributable risk. It means that if we limit to dementia before age 80, sort of the first half, maybe half is by age 85, then having one risk factor or more of vascular risk factors gives you a population attributable risk of 20 to 40%. So that's higher than some other estimates, but it's limited to before age 80. On the other hand, if you look after age 80, then having at least one risk factor is a population attributable risk of closer to 5%, a little more if you measure it in early life risk factors. So really a dramatic difference between whether you look at before or after age 80 cases. So now I wanted to transition to the next chapter of this talk, which is to think about biomarkers for dementia. So if we say that dementia often occurs after age 75 and the last half after age 85, that's a very long time to go. And prevention, if the midlife risk factors are the most powerful, may be the most powerful early on. And initially, we were worried that preventing late may actually be very hard. So biomarkers have evolved, and it's an exploding field where there's just literally, at the last, AIC meeting, hundreds of presentations on dementia biomarkers, which can be measured by brain imaging. And we're doing a lot of that for both vascular disease by MRI and Alzheimer's disease by PET. CSF markers are evolving, and then blood biomarkers are really very exciting to me because they're the most accessible. So I'll end up talking about that. There's been a lot of work in many cohorts, including ERIC, about discovery using blood proteomics, and there are many groups working, including Keenan Walker has done leadership of many of our papers, and it's amazing how you can get, with either Olink or SomaLogic, a huge number of proteins in a drop of blood, reliably measured semi-quantitatively for research purposes, but that's not the goal of my talk today. Today, I wanted to focus on the markers of both Alzheimer's disease, the A-beta 42 to 40 ratio, or p-tau, phosphorylated tau 181. We did not have 217, which is emerging as a better risk factor in the most recent data. And then NFL and GFAP as being two biomarkers of neurological damage, and I'll talk about more of those details when I present them in more detail. This is work in ERIC, published in 2024 with a senior author, Priya Palta. And what you see here is that midlife, more than 20 years before the onset of dementia, you get statistically significant associations. And in those cases, it was the Alzheimer's biomarkers that were associated. When you get to late life, closer to dementia, closer to 5 years or so, median of 7 years before dementia, you get association with the AD biomarkers that are stronger than in midlife. These are still risk factors at this stage, because you're years before the onset of disease, rather than using the markers for diagnosis, which is another context later on at the time of onset of dementia. This is risk factors for. And interestingly, the more non-specific neurodegeneration biomarkers are at least as strongly associated because we're looking at all forms of dementia. And we actually have a hard time distinguishing pure Alzheimer's from what we think is the majority of a mixed etiology of dementia. So then the final chapter here, I wanted to connect the observational work to randomized trials. And the question is, how do we think about connecting this and what are the implications for randomized trials? And I'll talk most specifically about the ACHIEVE clinical trial. So here I will transition to the ACHIEVE trial and its methods. Some of you may have seen it. It was published in Lancet about a year and a half ago. And basically the idea was that a hearing intervention was tested on slowing down cognitive decline. I'll show you the details of that, but the bottom line to start with was that there was a 48% slower decline, but it was only seen in the subgroup of participants recruited from the ARIC cohort study. So that finding is intriguing, and we're trying to follow up on that and understand some of the biology underlying that and what might be the implications for future trials. Cognitive decline was measured using questionnaires, but that means that it can be susceptible to some criticism in that there are learning effects over time. And that's really been a concern in a number of trials in that are people getting better or not slowing down as much because they're taking the test over and over again? And is that differential or non-differential? There could be a potential relationship of the testing to hearing loss, even though we tried to focus on tests that were not sensitive to hearing and made sure that people could hear the tests in a quiet environment. And then there's finally the concern of bias in unblinded studies in that people are unblinded and cognitive tests, are also, very subjective. So, we try and get the most reliability by having multiple scales, but in unblinded studies, you worry about that. So the idea is that blood-brain biomarkers may provide an objective measure of neurodegeneration and neuroinflammation, which would help us, form a more complete picture. So, I wanted to thank the ARIC investigators for the ARIC part as I take off into the ACHIEVE study, which was an offshoot of ARIC. I also wanted to take a detour to at least talk about one clinical trial that I think is particularly important for vascular risk factors, and this is the China Rural Hypertension Control Project led by Zhang He, where blood pressure in people aged 63 was lowered from a systolic of 157 to 128 over 4 years compared to the control group where it was 147, probably higher than we do in US trials, but probably not higher than many people managed in the community, right? And we had, a prior landmark study in the US, which had a reduction in mild cognitive impairment, but the reduction in dementia was not quite statistically significant. I think this study is dramatic in that because of its large sample size with over 30,000 individuals and having, over 1,500 cases of, or about 1,500 cases of dementia, the relative risk reduction of 15% was highly statistically significant for dementia, right? So consistent with the SPRINT MIND study, but more statistically significant, suggesting that while midlife risk factors are incredibly important and treating risk factors for decades is important, it is not too late. And you can look at people in their 60s and over 4 years potentially get a benefit of dementia of about 15%. This also happened for cognitive impairment of a similar magnitude, and the safety outcomes also looked very good. So returning to the ACHIEVE trial and hearing loss as a more general intervention, and this was led by Frank Lin, and I provided epidemiology expertise to his ENT specialty expertise and epidemiologic skills with a very large team at University of North Carolina coordinating the work, Hopkins with Frank and many people doing the work, the Mind Center at Jackson looking at the cognitive testing, field centers at multiple places, and cognition at Mayo, and University of South Florida doing the hearing intervention design with multiple experts, including Terry Chisholm. So the idea was that hearing loss affects cognitive load, brain structure and function, and social isolation, and together might accelerate cognitive decline and dementia. This was seen in observational studies, and the idea was, can we demonstrate that this modifiable risk factor leads to reduced rate of cognitive decline? So the design of the study was to give people a hearing intervention randomized against a successful aging health education control intervention, right? So we wanted to have an equal number of meetings with the staff so that there wouldn't be just this Hawthorne effect of whether attention is changing dementia. One could be concerned that if we do health education and meet with people, that may reduce some social isolation, and that by itself would have some effect. On the other hand, if that by itself has the full effect, then the incremental effect of hearing correction, is not that big. So I think we wanted to test this incremental hearing effect, hearing intervention correction, gold standard, and I'll show you how well people can do guided by the University of South Florida intervention team. The number of people randomized was 977, coming from an existing study, ERIC, which I talked about, and adding community volunteers. And this gets to a whole nuance of studies of dementia are typically by volunteers. Volunteers who worry about dementia may be different than people who are less able to run to the study. And in ACHIEVE, we focused on intact individuals. So we might have even aggravated that issue because we wanted to know, does hearing correction prevent the early cognitive decline? The study was done during COVID, so it's hard to ignore COVID, but we were very fortunate in that we enrolled rapidly before COVID. We did some telephone testing during COVID, but we were able to do an in-clinic exam at the three-year exam, so we were able to do an in-clinic visit and avoid the confound of telephone testing. We also recruited past our original recruitment goal of 850 to 977, and we got from ERIC 120 people on the hearing intervention and 118 on the education control versus a larger number of de novo volunteers. So by having 739 de novo volunteers, we were excited to maximize the power. And I'll show you that it was quite interesting as to what happened. Right? So what about the intervention? If you're going to succeed in a trial, you have to deliver the intervention, right? Did people use their hearing aids or put them in the drawer? Well, we saw that we had a median of 10 hours of hearing aid use at the 6-month time point, and that got reduced to 7 hours, but still 3 years later, we're seeing a lot of hearing aid use. And then some people going down to zero, about 15% going down to zero. If we look at the total group, ERIC and de novo, and we look at their self-perceived communication impairment, the hearing handicap inventory, you can see that the health education people had hearing loss. It was comparable to the hearing intervention because of randomization, right? The hearing intervention, the symptom reporting went way down and stayed down with some variability, and some increase later, but really dramatic reduction in symptom loss compared to the people who did not get the hearing intervention. At the end of the study, after this 3-year visit, around the 3.5 to 4-year visit because of COVID, we offered everyone the hearing intervention, and we're now following everybody. So there's the whole ethical issue of wanting to make sure people get interventions that might have benefit. And the percent with impairment, is comparable at the beginning and goes down to 22% in the hearing intervention at the 6-month, and some recidivism, but really a dramatic difference over time. In terms of satisfaction, how has hearing aids changed your enjoyment of life? 42% very much better, 41% quite a lot better. So with good fitting, it is impressive how much people can like getting the hearing aids. And do you think the hearing aid is worth the trouble? 74% saying very much worth it, and the other 19% saying quite a lot worth it. So now what happened to cognition, right? So overall, null effect. But what's interesting is if you look at the ARIC group, you get a 48% improvement. The de novo group was on the other side, not statistically significant. And what happened is that you see that the healthy volunteers or volunteers indeed had higher cognition at baseline than the ARIC people. So they had comparable or slightly worse hearing loss. But unlike what our expected is that the people with hearing loss would have lower than expected for their age global cognition, they actually had better cognition. And the rate of decline was faster in ARIC and improved in the intervention, statistically significant. On the other hand, it did not in the de novo with a p-value of interaction of 0.01. So that was dramatic and suggested that you get early benefits in people who have decline, and we've done a propensity score analysis of that as well, whereas the people who come but don't yet have decline may not be able to get cognitive benefit in the first 3 years. So now this final part of the presentation is to say, well, what can we do with biomarkers to really shed more light on this subgroup analysis? So we presented this at AAIC and are in the process of publishing it. So we focused on 2 neurodegeneration general biomarkers, neurofibrillary, sorry about the typo, light chain, and glial fibrillary acidic protein, right? And basically, they're increasingly used for screening, diagnosis, and monitoring and treatment response. So we wanted to see what happens in this context of a general population prevention process. We should note that the AD pathways may be involved as well, and there are the specific AD pathway biomarkers that are really used heavily for amyloid and tau interventions, but we think that they may not be as directly implicated in general interventions like hearing loss, so we decided to focus on general neurodegeneration biomarkers. And the question is hearing intervention is associated with improved neurodegeneration blood biomarkers 3 years post-randomization in the ARIC subgroup that showed slowed cognitive decline? Are we going to see that? And combining biomarkers and cognitive results, can that improve precision and power in subgroups which show treatment efficacy? So we basically had plasma collected at year 3 on 552 of the 997 randomized participants. This was the beginning of the extended follow-up of this cohort. And in the ARIC participants, we also had baseline plasma measures on 176 of the 230 participants. So we don't have everybody. And then I'll show you results for the biomarkers, the global cognition, and an average standardized score of the cognition. And then we average the NFL and GFAP after an inverse normal transformation. So we put all of these on a standard normal distribution, and then we average the biomarkers, give that half the weight, and with the cognition half the weight, and say, is that composite increasing the power in addition to looking at its components? So this is the baseline characteristics of the sample, and basically you see that the ARIC group control and intervention were comparable due to randomization and somewhat older than the de novo group, which was also somewhat healthier, and that's shown in the main paper, so I won't go into detail. And the number of people in the intervention who drop in or in the non-intervention who drop out and stop using hearing aids, or in the intervention who drop in and start using hearing aids, a little higher in de novo, but overall, relatively limited numbers. So what was our main result? Neurofibrillary light chain, looking at the 3-year randomized intention to treat result, we get the ARIC subgroup to be a p-value of 0.02, a reduction of NFL, and a reduction of GFAP, just like the cognition, where the other group does not show this difference and the overall group does not show this difference. If we look at reduced cognitive function, we see that there is a trend in the ARIC group, but by only looking at the smaller sample size and not controlling for baseline, because we're doing the comparable thing here where we only had measures on all of these people for biomarkers at the end, it wasn't quite significant. But if you do a composite, averaging the cognition and the two biomarkers, you get a more statistically significant result and a more precise result than any of the three other approaches. What if we did an intention to treat random effects analysis, including the baseline, in the ARIC participants in ACHIEVE that had data, 164 participants? Then you see that the effect in the NFL with a slightly lower sample size is in the right direction. The intervention is lower and slower, but they were also a little lower at the beginning, so that adjustment made the p-value 0.098. GFAP, you see again, the levels were a little different at baseline, but the intervention was very flat, whereas the control group had an increase, a p-value of 0.02. Cognitive function, now with the random effects analysis, significant at 0.05, and the composite significant at 0.001, showing increased precision with this composite measure. So in conclusion, this biomarker analysis showed that the hearing intervention leads to positive effects on neurodegeneration blood biomarkers in intention to treat 3-year analysis, limited to the ARIC subgroup, paralleling the cognitive decline results. And there's a suggestion that a composite outcome has greater precision and smaller p-values. So this is somewhat objective evidence of brain changes following a hearing intervention, and it adds to some observations we're making with the MRI subgroup in the study that had images. And it suggests a composite outcome approach. So then I want to show you a couple of slides before I conclude about what would happen if you tried to enrich for the trial using biomarkers. So in ARIC, if we look at the whole population versus the people in the bottom half of GFAP and NFL versus the top half of GFAP and NFL, you can see that people with higher biomarkers have more rapid cognitive decline than people with lower biomarkers, an average rate of minus 0.095 versus minus 0.058. And the top quartile is a bit more rapid, but then you'd have to reject more people from the trial. We replicated this in the MESA study thanks to some wonderful collaborators. And again, the same thing happens where the top half is more rapid than the bottom half, but the average rate using a different battery was slightly slower in MESA. And we also replicated this in ACHIEVE, and James Pike is working on publishing these results, which were presented at AAIC. And in ACHIEVE, by the time you're at the 3-year follow-up and you look at subsequent decline, the average decline remains close to 0.014, but in the people with the biomarkers, you get minus 0.054 and many progressors, whereas in the people with the low level of biomarkers, the majority of the people in the bottom half of the biomarkers are non-progressors. So you can see there's this idea that if we selected for trials based on biomarkers, we would get more progression, and we should have more power and a lower required sample size. So just as an illustration, if you use the ARIC assumption and you look for a 33% lower decline in cognitive function due to an intervention, if you use the full sample, the sample size calculation was 600. If you actually use the bottom half, it becomes of biomarkers more people, whereas the top half, it gets down to 400. So if you screened and rejected people in the bottom half, you actually could do a much smaller study. And the same sort of thing was happening in MESA. And in ACHIEVE, when we look later at the follow-up, the rate of decline was so low that if you just reduce by a proportional amount of this rate of decline in the full sample of minus 0.01, even if you eliminate it at all, it's not enough of a gain, right? So we do have to worry that in the first few years, healthy volunteers may not decline very much. And if we want to look at decline, now some studies have looked at increase in finger and point, but if we want to look at decline, and if our hypothesis is that we reduce decline rather than produce more of an increase, then we better get a population that has a rapid rate of decline, and high half of the biomarkers may get us there, top quartile may get even more. So we need to study this in multiple groups. I think it's also important, before I conclude with ACHIEVE, is that cognitive decline is just one benefit of hearing intervention. The study looked extensively at brain atrophy, social isolation and loneliness, risk of falls, risk of fatigue, and communication functions, where we see benefits across multiple domains, and that's important to look at. But cognition is an incredibly important outcome in and of itself. So I want to thank the big ACHIEVE study group, and I talked to you about the different universities involved. And the final conclusion slide for my talk is I wanted to make a few points. I think dementia epidemiology should guide policy and practice. I think the lifetime risk of dementia, our estimate is 42%, and half the incidence is after age 85. There are several papers forthcoming, so I think we'll see how the thinking is evolved, but I think we do need to worry about this very late life risk. Competing risk is important, and it can reverse observed association at the oldest ages if a risk factor is very strong for mortality and even more stronger than it is than for dementia. Dementia risk factors, huge implications for prevention. I think the Lancet Commission outlines this incredibly well, with the risk factors and the potential for about half dementia risk potentially being preventable. But you have to look at the nuances, think about dementia before age 80 and after age 80, having weaker relative risks and weaker population attributable fractions, and potentially higher population attributable fractions at earlier onset. You need to think about the timing of the risk factors that matters. And finally, I think blood-brain biomarkers. There's a growing huge literature, and I tried to show you some of our latest thinking about the ideas for improving clinical trial screening and possibly combining it as an outcome in prevention trials. So finally, I want to thank you for listening. I want to thank the members of the ARIC collaborators, which includes over 100 people and over 1,000 people using the data, students who have worked on the data, and the participants themselves who have given decades of their lives literally to coming back for visits. And I hope that together we can work on optimal aging. Thank you.
Dr. Koresh, thank you very much for this really great overview of your work. Very, very exciting. Great achievement, if I may use that term in this case. We have quite a number of questions in the chat, and I would like to ask, I would rephrase a few, but would like to ask a few questions about that. A point you mentioned, lifetime risk, 40% or so. Yes, I think the Europeans in a Rotterdam study already observed that to a large degree when you look at the white population quite a number of years ago. So I think that's a very reasonable estimate, and probably even if we go on with life, perhaps even an underestimate still. I agree with your assessment there. There was a question I thought interesting on the population attributable fraction of vascular factors. They go down from midlife 40% to 5, perhaps 10% in late life. Very, very interesting. But in the biomarker sphere, particularly looking at NFL and GFAP, it is the other way around. It gets more. Perhaps you can speculate on that, why that is.
Yeah, so wonderful question. I've been thinking about it for a long time. I'll give you some thoughts. You may have others. And as you said, you guys have done wonderful pioneering work in looking at the lifetime risk. And I think we need to continue to do that in multiple cohorts. So in terms of vascular risk factors, right, the population attributable fraction is high for dementia before age 80 versus dementia after age 80, right? And then we have the other part of when the risk factor itself is being measured. So the risk factor itself, often we see midlife risk factors being very strong for the early onset dementia before age 80 in ARIC, but I still think we need to look at other cohorts and compare it and look at meta-analyses. The late life blood pressure was still quite predictive of the 10-year risk. Now this is late life age 70, not age 80 or so, and not 85 when you're trying to predict the dementia after age 80. The biomarkers, I think what's happening is we were predicting all dementia, so that's a little bit different than trying to distinguish subtypes. And I think it's very important that biomarkers are both risk factors for and very much outcomes markers of. And often when you get markers of disease, those become much stronger later in life. And I spent decades studying kidney disease and then expanded from the heart to the kidney to the brain. So there you very much see that risk factors like lipids and blood pressure in midlife are very strong and kidney disease is rare. Whereas when you get to older age, end organ damage, kidney disease, heart failure, NT-proBNP become elevated, and things like blood pressure have both forward and reverse causation, so become more complicated in late life. Long answer.
No, no, very, very interesting, and it makes a lot of sense to me, your comment on that. Um, there was an other question, looking at, well, a basic question actually. This difference between men and women. I come back to the first part of your talk. You said it's the risk and the rate, huh? And you basically lifetime risk for women is larger, but the incidence, so the new disease of the disease, is really not very different between men and women. Is that a right approximation of your findings?
Yeah, that is true in Eric. I still
Right.
think there are a lot of studies that show also a higher hazard in women. And I think the issue of what happens perimenopausally is particularly important because I think perimenopausally you get changes in cognition, which may be well short of dementia, which happens 20 to 30 to 40 years later. So I think unarguably, because women live longer
Yeah.
and more of them survive past age 85, more
Prevalence is higher.
women are experiencing dementia and have prevalent dementia. The exact magnitude of the increased hazard, age specific for the earlier years, I think is quite interesting. And perhaps Eric underestimates this. You can talk to other studies, but I think we need to think of both factors, is what I wanted to
Right.
highlight.
Right. Thank you. Um, Final question in the chat as well that I rephrase a bit, but I thank all the many viewers. I'm sorry that you cannot more directly be involved because we have a limit of 300 people, and there are many more of you that applied, and so we had to put it in a webinar form. But in any case, um, a question on that you mentioned it, achieve study, hearing intervention, and cognitive decline. What is the possible effect of the subjective assessment of cognitive decline? You refer to that. Can you speculate a bit further on that and how you try to resolve that, particularly in your various subgroup analyses? Can it still have affected your findings?
Yeah, so we've worked, as we always do, with world leaders in this. So the Cognition Center was led by Tom Mosley, and
Yeah.
David Knopman was, a key reviewer for adjudication, along with Marilyn Alberts and Rebecca Gottesman and Keenan Walker and others. Um, so I think these are state-of-the-art assessments using multiple tests. And so they have good psychometric reliability. But you do worry that cognitive testing is influenced also by mood and may be
Yeah.
influenced by the exact tester. I think, and just as a general statement before we close, I wanted to thank you for inviting me and make sure that it's clear this work was by many, many people. I'm presenting a subgroup of it. And we're continuing this work here at NYU and welcome people joining us here and in other Eric centers, including on the research. Uh, so I think the biomarkers was a nice way to address this issue where we thought it was real. I think reviewers agreed, but it's nice to see multiple lines of evidence. And I think that's the nice thing about this evolving literature on biomarkers, that we can get corroborating evidence to a strong implication on cognition, which is the most important thing. Waiting for dementia often is infeasible in a lot of trials, unless if you start very late. So I think looking at triangulating across multiple things is stronger.
Dr. Koresh, Joe, thank you very, very much. I know we stop a bit earlier, but we have a change in terms of our teaching schedule, so people have to go to other places. But it was a very enjoyable and insightful, I think also, seminar of an really important topic, and I thank you very much for doing this. I wish you and Eric and all the other people who work on this also at NYU now all of the best, and we invite you all again back next week, same time, same place, on Zoom for a further seminar. Thank you very much, Dr. Koresh.
Thank you, and thank you for your leadership in this field.